Good afternoon, everybody. I apologize for having to put other films impromptu performance. I'm Waseela Khan, and this afternoon I'm honored to be part of a panel discussion where we're going to be discussing the future of emergency medical care. Now, as we celebrate 15 years since emergency medicine has been recognized as a specialty in South Africa, we look back and we reflect on our accomplishments. We started from a handful of practitioners that practiced in the casualties of yesteryear and have developed into a specialty that has its roots firmly planted and extended to include pre-hospital and nursing emergency care. Now, it certainly is not difficult to understand that the development of emergency medicine in South Africa is actually a shining example of what can be achieved when few people with the very same passion and commitment combined with a view towards patient care can achieve so much. Now, they say that women in the world hold up half the sky. I am fortunate today to be accompanied by an entire posse of amazing women who are going to help me to hold on to this discussion and break down the bigger issues around the future of emergency medical care in South Africa. Granted, in half an hour, but we shall do our best. Okay, so please allow me to introduce. We've got Mom, equestrian emergency physician to boot, and holding together pretty much the entire emergency centre at Karl Bremer Hospital. We've got Sue Le Roux. A very familiar face and a legend in her own right, a senior professional nurse at Somerset Hospital. We've got Wendy Scorbinsky. You know what it is? It is the sieve in my memory banks. I blame my kids, but they're not taking responsibility. Okay, and then we've got one of the very first emergency physician graduates in Africa, as well as mum and head of emergency medicine South Africa for the Mediclinic group. I honestly don't know how she does it all. It is Melanie Stander. And last but not least, and actually the first female advanced rescue practitioner in EMS, now EMS District Manager, Shakira Hartley. Okay, so when we consider the future of emergency medical care, there are three components that come to mind. The first is people, and that includes patients and us, the workforce. The second is technology and innovation, and of course thereafter it's the socioeconomics that actually drive healthcare. Now, Wendy, allow me to start with you. I regard nursing in healthcare our stalwarts. Certainly, you are perfectly positioned in healthcare, holding the fort of the casualties of yesteryear, and so perfectly positioned to see the transition of not just emergency medicine, but of emergency medical care in general. How do you considering the patient demographics and our burden of disease and the current trend, how do you think that these components are going to impact the future of emergency medical care?
In terms of patient demographics, we are seeing a lot of young patients, teenagers, young adults, as well as retaining the geriatric load. There are high rates of poverty and unemployment in the country, and the communities are struggling to survive, I think. The quadruple burden of disease is on the increase. XDR, MDR. In addition to that is our drug-induced psychosis. That's also on the rise. Then we have our younger generation, particularly I'm speaking about teenagers, We have incidences of overdose as well. And this is quite difficult for us to manage because this is fueled by our socio-economic imbalance in the country. And if this trend continues without any reform soon, patient care, quality patient care, will be near impossible to reach. As it is, we are already struggling with resource constraints and battling with staff shortages, high absenteeism rates, as well as staff burnout.
Thanks, Wendy. Shakira, does this match the statistics that you're finding in EMS at the moment?
Thanks, Waseela. I do think it does, to a certain extent. I think what we are all experiencing, we're experiencing holistically, whatever effects that it has on one department or unit, it has on another. So if I can just give an idea of what EMS, Emergency Medical Services, is sitting with at the moment in terms of numbers and calls, and we service about, there's a lot of statisticians in the room, I know, so you can get me after this if I'm not right. We service about, or we get about 600,000 calls per annum. So we can split that number into two parts. So I'm talking about the city and then rural services as well, or rural districts, sorry. So we are servicing about 360,000 calls within the metropole, and then about 240 in the rural districts. So what I'm trying to say is that calls we are receiving in terms of population growth, we have been not matching the amount of the workload has remained constant over the last 5 years, but it has also become hard on us in terms of resources. So if we are looking at an amount of 150 ambulances that we have at the start, about 1,500,000, we are actually not making or getting into the mandate that we should have. So basically what I'm saying is 5 years ago, we had a mandate of responding to any call or any area under 15 minutes. We cannot do that anymore because we're looking at about 20% of that compared to 5 years ago. And in that, we, in a perfect world, we should have had maybe about 500 ambulances with 5,000 staff, and we don't have those numbers to deal with exactly what Wendy was trying to say. So with that, and we speak about the burden of disease, socioeconomic circumstances, and then also the biggest and the latest thing that actually happened too, and in EMS, which is not new, is the attacks on ambulances lately, and that is having tremendous effect compared to what it's always been there, but I think it's just had, it's added an enormous impact on all our services holistically.
Thanks, Shakira. So I think you've both highlighted significant dividends in emergency medical care, and the emergency centres in particular have become these sociological microcosms of society that provide a lens into a very fragmented healthcare system. Now, there's a notion that's shared by quite a few of us, I know, is that we become frustrated by the many non-emergencies that attend, or the social catastrophes that present to our emergency centres. And I see that as being, the product of a system where the supply, or rather demand, far outweighs the supply. But perhaps, are we looking at this differently? Are we not placed in the perfect position for conversation, for collaboration, for change? I do like this emerging concept of social emergency medicine, which basically steers away from the biomedical approach to healthcare and instead focuses on the biopsychosocial aspect of patient care. Whatever it is, I think change is inevitable. And speaking of change in South Africa, that is probably going to come in the form of the national health insurance. Now, many consider that, well, if you consider the country's current economic state, our high unemployment rates, our very strained tax base, many will say, well, we think this is a futile exercise, but whatever it may be, it is going to impact both government and private health sector significantly. Mel and Sue, I put to you, what do you think that impact is going to be, and how or what strategies may we implement to be able to survive the implementation of the NHI? Mel?
Thanks very much, Waseela. So, Mediclinic as a company, we are extremely supportive of the principle of the national health insurance. The principle of having access to healthcare based on need and not on the ability to be able to afford that healthcare. We've had the recent draft bill that's been released a couple of weeks ago, and I think there's been a lot of scrutiny by a lot of individuals and organizations on this draft bill. We're not going to be able to preempt what the final bill will be at the end of the day look like. But what we will be able to do is start engaging and having a lot of public participation and discussion about what that final bill will look like. And essentially NHI is a healthcare delivery system. It seems to be the envisaging of the system is going to be a staggered approach, if you like, and not necessarily completely implemented in one sort of D-Day as such. And what we envisage is that will probably be a big focus initially on primary healthcare and some other clinical services, which will be focused on eventually, and then possibly a further expansion of that over time in a sustainable and a slow manner to include other service provision. But essentially the important thing really is to leverage on their expertise and the health resources that we have both in the government and private sector to be able to implement this. Yes, there are many challenges considering the current socio-economic issues that we have in the country, the macroeconomic climate, the microeconomic climate of our individual citizens, as well as the issues we have with a lot of healthcare facilities. However, we very much see that we want to be a part of the solution. The private healthcare industry very much wants to be part of the engagement and wants to work on this journey together to be able to execute this dream of social solidarity related to healthcare for all our citizens.
Thanks, Mel. Sue, how do you think this is going to impact the government sector?
It's really hard to say. It is tough on most days where we are now in a resource-constrained environment. And I think it is going to depend to a degree on how it's implemented, which Mel has touched on. I think it's also fair to say that for many people at the moment there's no trust in this process. It's not necessarily to them a completely transparent process. And I think one of the things that the drums that I want to bang is the importance of differentiating between universal health coverage and funding universal health coverage. It is impossible to argue in South Africa against universal health coverage. It cannot be argued that it is fair that 80+% of our citizens don't have reliable access to good health care. And I think that if our understanding of how NHI is going to happen and how it's going to be funded is true, then there are going to be a lot of people who used to have insurance that are going to have to access healthcare in a different place, in a place that possibly they didn't use before. And that is going to be our public emergency centres. And so the volumes and the burden and the load is going to increase. And something that my work husband, Almira Oosthuizen, and I like to call the expectation-reality mismatch is going to become ever more common. You know, come in expecting the red carpet and discovering an 18-hour waiting time. So in terms of strategy, for me and for my team, I love Richard Branson, and I share his view that if you look after your people will look after your patients. Okay, he doesn't say patients, but I do. And my primary customer is not the patient walking through my door. My primary customer is my medical officer that I need to look after, nurture, koester, as they say in Afrikaans, so that that person can remain in the job delivering quality emergency care. I think we need modern thinking and novel approaches. We need to remember the concept of our sphere of influence. If I'm trying to change something that's over there on the edge of my sphere of influence, I'm going to be less successful than if I can just focus where I actually am and where my skills and talents are. And we need to be the clanging bell, because we just need to keep on saying what we need to say to the people above us until they hear us with their hearts. And then to finish off, I think my long-held belief, if everyone just does what they are supposed to do, it would be a good place to start.
Thanks, Sue. I think you've both touched on a really important aspect here, and that is that change is not going to happen by itself. That change is going to have to be led. Especially at the institutional level, we are going to need clinician and practitioner champions. We're going to need strong clinician leadership. Yes, we desperately require infrastructure changes, but we shouldn't underestimate our potential as front-facing practitioners. We need to break the mold and truly be innovative. Now, Sue, you've discussed taking care of our people, and I'd like to touch on the issue of gender-based violence, which has received significant public and media attention in the past few weeks. As a woman, as a mother, and an emergency physician, these challenges are not new to you. And in your opinion, what impact do you foresee these issues having on emergency medical services? And if the future is women, how may we strategize to ensure a strong, gender-balanced workforce of the future?
Yeah, this is one that you've got to be careful what you say and where you say it. The past few weeks have been very impactful. Many of you may know I have a 16-year-old daughter, and there have been some really gritty conversations at home in the wake of some of the events that have been in the news. So if we're honest, if the tide is not stemmed, the practical reality is going to be that our emergency centres are going to see more trauma victims, and our Tutuzela centres that take care of our victims of sexual assault are also going to be busier than they currently are. So a simplistic answer would be to say the 3 S's. We need more staff, stuff, and space. But as you've already pointed out, infrastructure doesn't happen overnight, and the funding is just not always there. So is the future women? I certainly hope it includes women. But I am a firm believer in competency first. And that competency, within that competency, or search for competency, there must be balance, gender balance. If we think of it in practical terms again, only women can have babies. Maybe that will change in 20 years. I think the first transgender birth just happened about 2 weeks ago in the UK. But only women can have babies. And so women who are nurses, paramedics, doctors, fulfilling any role in healthcare and provision of healthcare may need to take time off at a point in their career. I am told, without any confirmation, that up to 70% of the medical students at Tygerberg Stellenbosch are currently women, female medical students, and all of these graduates are going to come into the job market, but more especially into the provision of healthcare. So I think we need to start thinking a little differently than we have done up to now. I am not asking for special treatment for myself, but we do need to adapt our systems. We have to stop with the old-fashioned thinking of got to do 56 hours a week, have to take a full job, has to be 40 hours, has to be 16 hours of overtime. Why can't we job share? Why can't we have 5/8 posts? Why can't we have posts that don't have overtime? If 2 women who want to have time with their families are prepared to share a 56-hour post, split down the middle, and each take their portion of the night work, why is that not possible? Why is there such a barrier to that kind of thinking? It's something I don't understand. We've had people in my own hospital resign recently because they were not allowed to give their overtime to somebody else. So I think we really need to start having a more default yes position, and let's think about that, and let's see if we can explore. And we say women, but it applies to men too. Not all men want to work a full 56-hour-a-week job with overtime. So it comes down to being practical and actually not just saying no for the sake of saying no.
Yes, Sue, I agree. I think there is a dire need to adapt the working environment to appreciate our gender differences, but without that bias. Mel, you are the IFM immediate past chair for gender-specific issues special interest group and a successful EP in your own right. In your opinion, what strategies can we implement to ensure that we have a stronger balanced, gender-balanced workforce for the future?
Thanks, Waseela. So, essentially, I think some of the issues also relate to the fact that it's not just in South Africa where we're struggling with a lot of gender-based issues. I've found a lot of speaking to colleagues internationally from different countries where emergency medicine is practiced, they suffer from the same issues. And then what you end up having is possibly a woman starts second-guessing a specific career, they start fearing for their safety, or they start changing their behavior or routines because of certain environmental factors. And then also as emergency medicine healthcare professionals, we also see the result of what happens relating to these issues in society on a daily basis. So I think from a strategy perspective, there are a couple of issues. I know Sue alluded to some practical components, but I think one of the basic things to consider is really just issues about gender bias and discrimination. And I don't necessarily just mean male and female, but cisgender as well. And how do we relate to each other, and how do we reinforce stereotypes unknowingly? Because I know I am guilty of that very, very often. It's very easy to fall into a sustained way of thinking, which reinforces a stereotype, which dictates a certain response in society. And we need to really start just questioning the way that we respond to things in that way. I think the other thing is specifically issues about a fair and equitable workplace, as Sue was alluding to, for everyone, not just for women, but really to make it a place that is equitable and fair for everyone involved in providing that care. And I think another important component is obviously the fostering of leadership of women in emergency medicine and in emergency medicine careers. And I think if we also reflect as healthcare professionals, we are very often have that ability to be the first contact and to be that empathetic healthcare professional that has contact with victims of gender-based violence. And if we can just possibly be the start of their physical healing, it will hopefully aid at the end of the day for the whole healing of that person, which we understand is very much a journey. And obviously we don't work as healthcare professionals in isolation in our workplace, we also come from communities. So how do we start implementing a lot of those strategies and considerations back where we live and the people that we interact with on a day-to-day basis? But it isn't easy, I agree.
Absolutely. Thank you, Mel. You've given us some great food for thought there. Wendy, I'd like to hear your perspective, considering that it is the majority female workforce in nursing care.
The female workforce in nursing care. In terms of the workforce in nursing care, it is important to have a gender balance. As you know, females in nursing are more dominant in numbers, yet men have better opportunities in career growth. So, as you said, we should not ignore the physiology, because women may require to go on maternity leave and they may require contractual reconstruction, but there shouldn't be an impact on our career growth. So all women should be respected, and they must be provided a better opportunity in a safe working environment.
Thanks. Okay, well, I completely agree. I think the future has no place for bias or prejudice and gender inequality. On the topic of safety, emergency medical services has had quite a bit of media attention recently, and interventions at EMS have been applied to try and mitigate these insults on the service. Shakira, what trend do you foresee for EMS of the future in terms of workforce?
I think we have just picked on a really sensitive topic, I think, in where we are today. And the last week, I think we've had as South Africans for the last 2 weeks. I have a lot of colleagues in the room right now, EMS and paramedics and all the people that are on the road. You guys know what I'm talking about. So it's a sensitive topic to me because I was a paramedic. I am a paramedic myself. I spent 18 years on the road before I became a district manager. And it wasn't easy. And I think I lost everything I wanted to say, so I'm just going to speak. I think it's important for us to actually see how things evolved, and I was fortunate enough to see that. And I think if I think back, 2003, myself and a colleague of mine were assaulted in 2003. So I think back about when attacks on crews and ambulance staff and public servants, and it has happened a long time ago over a long period of time as well. So I think what has changed was we could start speaking about it. We could actually start talking about the fact that as much as what some of us actually have to relate to incidents and violence and abuse and everything else that we take and deal with after work, because some of us have issues like that at home, but I come to work and I have to deal with that too. It's very different because the emergency medical services, they are unique. I think we are so unique. Paramedics and everybody out there are so brave. We go out into people's homes that we have no idea who they are, and we just do what we're supposed to do. And I think our conversations have to change. Our stories have to change. I think we have to speak about what we're dealing with, and you know, the attacks have become more, and if I can say, more blatant in a way. So what we try to do is, it's like asking, you know, how can we try and prevent attacks? Can we really prevent an attack? I don't think so. I don't think we can prevent an attack in the next 10 years unless you're really sending out there with body armor and, you know, but is that how we operate? I don't think we do. So what we tried to do in EMS was actually try and form a, you know, we have safety committee, and we try to form relations and relationships with other stakeholders and people that exist in our community that we can build relationships with. And as ridiculous as what this might sound, is actually to protect our ambulance people, to protect our colleagues. We are asking the very communities out there that we decide, I'm going home there tonight, and I'm asking you that when I put on my green and red uniform, that you protect me when I'm at work. So it's something to think about, you know, it's really something we need to think about, because in terms of being a paramedic and where I used to be and where I come from, I expect the same people as a district manager now to do the work that I used to do, and also relive the effects of assault. And I never thought I'd be in the position, in terms of being a district manager, that when I can sleep at night, I worry about the next time one of my colleagues are going to be attacked. It's a crazy conversation to have with yourself. And it is also, if I can say, it's opened up my eyes. The lights went on a couple of years ago. I think 2014, 2015, the lights really went on for us. And we have put a few things in place that not protect us 100%, but we strive to try and make things a little bit easier for our ambulance and colleagues out there. And yeah, I think it might not get any better, Waseela, in the next 10 years. And if you speak about, you know, I think the state of affairs in our country, and in Cape Town especially, has been rough. It's been hard. It's been rough for a lot of us. And I just think we're at that point also where we just have to come together and look after each other, no matter where we come from. I just think we should just have each other's backs all the time.
Thank you, Kira. Yeah, it is that sense of taking care of your people, isn't it? And it's very difficult conversations to have. I think there's no quick fix solutions. I know EMS has been looking at technology to assist in promoting safety or to ensure safety in some form or the other. the use of body cams, of traffic management system. And so, you know, that brings us on to our next topic, and that's really technology, because we cannot have a discussion about the future of emergency medical care without considering technology, right? Okay, so certainly in the Western Cape, MS is far ahead with the computer-aided dispatch system, electronic patient report forms, mobile data technologies, as well as the wall boards in emergency centres. But so if I could ask you, where do you see technology in emergency medicine in the next 10 years?
Well, it just has to be there. I think it's critically important. If you think of the hours of time that the average nurse, especially the nurses and doctors, spend writing notes, writing requests, sending orders, the amount of duplication that happens, you send the same information to 5 different people. Technology can really make a difference for us in terms of time management. And until you've been on the sharp end of legal action and the notes of the patients are lost, and it's the last bastion between what you think you did and what you actually did, it's a state of terror that you don't want to have to live through. So I think technology does a lot of things for us. It minimizes error. It gives us good data. It provides an undeletable record of what was done and said. It saves time. You're well aware that we have a migrant population of health seekers, you know, in the Western Cape. We have people coming from all over the country. They come and say they've got a thing, but we have no access to their records. Imagine if that was different. Prescription errors, when you've got forced fields and drop-down menus become much less. And then imagine a world in which you never had to try and decipher my handwriting ever again. I think that there's amazing equipment out there, advances every day, new stuff coming up, and I think that in a country that sorely needs our population that can contribute, the tax base back in work, imagine if we could use technology to get that right more.
Yeah, I'm completely with you on the handwriting aspect.
That's harsh.
Absolutely. But also the need for a fully integrated system.
Yeah.
Right? This is something that needs to be able to chart the patient journey from the very beginning to the very end. It needs to be an integrated system, and it needs to be one that has the infrastructure and that has 24/7 support, that is national and that is accessible. Wendy, I'd like to hear what your opinion is. I mean, how do you consider the nursing part of our team going to embrace technology in the future? Will they?
Technology will definitely improve healthcare by early diagnosis, early treatment, so we can have better outcome for our patients. We will definitely have a better workflow, as well as, I think this will translate reduce cost in healthcare as well. And data storage would be much easier. I'm sure everybody would agree on that, just go paperless. So it's much easier, much safer, and I also think that when we need to access data, it would be easier at facilities, it will be available at each facility to just treat our patients. Data is immediately available for the patients. It will also create a communication between our healthcare workers, and what will be great is that we'll be on par with worldwide best practices.
Fantastic, thanks. Mel, do you share the same opinion? How do you think technology ought to be implemented?
Absolutely, I want to very much echo what Wendy said, and I think where we're going to leverage on technology for emergency medical care going forward is on leverage on efficiencies in our system, integration of data. So currently now we can, it's not really our realm from an emergency perspective, but in an ICU you can have a patient lying in an ICU in some location with a robot next to the bed, and 4,000 kilometers away is the ICU specialist who's on call for that ICU. They're not physically there, but they're actually doing the ward round with the help of the robot. That's what's happening at the moment. Right through to a scenario, for example, wouldn't it be wonderful? A lot of people are wearing personal, I'm not, but some people wear personal health tech gadgets, okay, constantly monitoring, it might be anything from your insulin levels, your blood pressure, your heart rate. You are maybe predisposed for whatever reason to a bit of arrhythmia development, and an arrhythmia develops while you're at home and you're not quite aware yet because you haven't maybe got significant physiological derangement. A couple of minutes later, your doorbell rings and there's an EMS service and they want to take you through to hospital to get checked out. You weren't even aware there's anything wrong. Off you go. And by the time you get to the hospital, all your records are there. They know exactly who you are, what's happened in your life for the last 25 years. And they've also contacted the most significant maybe doctor who you're usually seeing in connection with this condition, and they're already aware of the fact that you arrived in hospital with a potential issue. This is not fantastic future Star Trek stuff. This is we all can do today. I think what's going to happen going forward, it's going to start to become a lot more common. How we integrate and leveraging on all these sorts of tech gadgets, integration at hospital facility-wise, how do we streamline our system that it becomes a lot easier, and at the end of the day we get efficiencies related to instrument, about the data and extraction of all that, the flow that both of you have alluded to, and at the end of the day that we integrating all of that with at the touch of our fingertips, and it's quick and it's reliable. That's where I see it going.
Yeah. Thank you, Mel. It is clear from our discussion today that the inadequacies in health are a direct result of overcrowding, an overwhelming burden of disease, inefficiencies, and a dwindling workforce, really. And I think our future depends on the ability to be able to resolve this conflict. So where do we go from here? So much of work needs to be done. We need to end boarding of patients in emergency centres. Technology may be part of our solution, but it certainly alone doesn't hold the answers. We need to become innovative, and we need to consider how technology can actually improve our patient care. But we can't let technology lead us. I think we need to provide quality, efficient healthcare, and this may include adopting the social emergency medicine concept, where we become critically conscious healthcare practitioners that consider the biopsychosocial aspect of patient care. We also need to continue to train the best and the brightest practitioners. I do believe that we can and we should lead the house of medicine in this health transformation. And these goals are achievable. Everybody sitting here today has in them the native trait of ambition, of being flexible, of being hardworking, but above all, being able to put patient care first. I think our future really depends on us developing a strong team. And in order to do that, we really need more of us to be able to share that load. And while we are busy with the expansion of our specialties, we need to make certain that we are putting together quality training programs. We must increase our research output. We need to understand the African context. We need to explore methods of healthcare that is appropriate for our context, and together with integrating with the wider communities of practice in Africa, we need to determine what is best practice for African emergency care. I'd like to, essentially, we need a team that is gender balanced, that is strong, that is committed, that is respectful, and that has strong leadership who invites change and innovation. I think if we continue this way, and if we're all committed to the same purpose and share that mental model, then our future is actually bright. So with that, I would like to thank those few before us that actually created this unique specialty of emergency medicine and continue to be dedicated towards its improvement. However, I think that it's time to cross over the next frontier, and we need to make African emergency medical care stronger and better. And with that, I'd like to end by thanking my panel for your input into this discussion. But most of all, I'd like to thank you, all of you, because you are the change that we need. The future of emergency medical care depends on all of us. Thank you, everybody, for your attention.